Sir, please start.
Good afternoon.
Hi, Seema.
Hi.
So good afternoon, everybody.
Somebody was talking to me and I got a call from hospital, so I could not talk to her.
Same thing happened to me. I had calls and I got delayed. Otherwise, I'm usually 15 minutes early. Nirima, you can go full screen, please.
Hello,
Hello,
sir.
Pratik.
Welcome.
Pratik.
Welcome to ICOG program.
Good evening, Pratik.
Good evening, sir.
Am I audible?
Yes, sir. Audible, visible.
Good evening to all of you.
Yes, sir. Good evening, sir. Can we start, sir, with your permission?
Yeah.
Yes, let's start.
So good evening, everybody, and welcome to the Foxy ICOG Tarun Abhiyan CME, which is this month on reproductive medicine. And the purpose of this Foxy ICOG CME is to give a platform to our youngsters, especially those of who have actually been trained with the Foxy certificate courses. As you know, Foxy and ICOG do certificate courses for 6 months and 1 year in reproductive medicine, endoscopy, ultrasound, and fetal medicine as well. And I'm one of the conveners along with Dr. Madhuri Patil for the reproductive medicine course. These are students who are going to be speaking today in this Foxy ICOG Tarun Abhiyan CME who have passed out in the previous batches of this ICOG reproductive medicine course. So without further ado, let's get started. Next slide, please.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
So today's program is a power packed program where we're going to have 3 talks first, and then there's going to be a debate. It's a short, sweet, and focused program on the most important aspects of reproductive medicine, which are important from the point of view of a general OBGYN, what it is essential for them to know. I would like to first welcome on stage our Secretary of ICOG, Dr. Sarita Bhalerao ma'am. Madam is a past president of the Mumbai OBGYN Society, currently a secretary of the ICOG, and she's also been chair for the West Zone of the RCOG as well. Over to you, ma'am, for the inaugural address.
Thank you, Pratik. And I welcome all of you to this webinar on Tarun Abhiyan webinar on reproductive medicine. This is the second in the series. We had one on fetal medicine a little earlier, and we hope to have a few more before the year is over. I'd like to thank Dr. Sunita Tandulwarkar for giving us this opportunity to do this and congratulate Dr. Parag Biniwale. It was his idea, and I think it's really a fantastic idea to have our young, enthusiastic trainees, fellows, past fellows who participate in this program. And congratulations to our dynamic convener, Dr. Pratik Tambe, for putting together this program. I welcome our mentors, Dr. Tushar Kar, Dr. Ramani Devi, experts in the field, and judges, Dr. Fessy Lewis and Dr. Seema Pandey. And a warm welcome to all our speakers, Dr. Raksha, Dr. Upma, Dr. Shazia, Dr. Mahima, and Dr. Sukriti Singh. So thank you very much, and I'm sure it's going to be a lovely evening. Back to you, Pratik.
Thank you very much, Dr. Sarita ma'am, for your blessings and guidance always. And I'd like to now introduce our chairperson of ICOG, Dr. Parag Biniwale. Sir is a past president of the Pune OBGYN Society, also been president of the Pune Menopause Society.
Thank you, Pratik.
I know him since he was secretary of ICOG, and of course, we all look up to him immensely. Thank you for your blessings and guidance always. And thank you for giving me this opportunity to conduct this reproductive medicine ICOG Tarun Abhiyan series. Over to you, sir.
Thank you, Pratik. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to connect with you all again on the second episode of ICOG Tarun Abhiyan. In the month of April, during the cell meeting, I was part of the youth cell, and it was decided that we should give a platform to our youngsters on a national level, and that is how I picked up this idea. And I must thank Dr. Sunita Tandurwadkar, the president of Foxy, and of course Dr. Narendra Malhotra and Dr. Suchitra Pandit, who are the conveners of the youth cell. Uh, Couple of months ago, we did have a first Tarun Abhiyan on fetal medicine, and this time we thought of having it on reproductive medicine. The basic criterion of the speakers is that they have to be trained by ICOG. So we thought that we should include, uh, youngsters who are trained in the ICOG certificate courses. I very warm welcome to Dr. Tushar Kar, past chairman of ICOG, and I had a pleasure of working as secretary when Professor Tushar Kar was the chairman. And of course, Dr. Ramani Devi, past vice president of Foxy, and she was a very enthusiastic governing council member during my secretary tenure. Pratik, I must appreciate your sincerity because just one phone call and the program was ready. I really admire your commitment, and we look forward to more and more contribution from your side. Special thank you to our governing council members, Dr. Facey Lewis and Dr. Seema Pandey, who will be judging the debate. And my best wishes to all the youngsters, because for the first time, they are going to be our ICOG speakers on a national platform. I'm sure you'll do well. We have mentors from whom we are going to they are going to give you some nice tips at the end of your presentation. So happy learning, everyone, and thank you very much. Enjoy the program.
Thank you very much, Dr. Parag Biniwale, sir, for your blessings and guidance and your words of wisdom. If we can get the program started now, I believe Dr. Sunita Tandurwadkar is unable to join us, but we will express our gratitude to her for this opportunity.
So
Nilima, if you can-
actually, we are in a meeting in Pune on thalassemia. So
Okay, sir.
there's some ceremony going on. I just ran out of the program and I'm sitting here.
All right, sir. We will not hold you back any longer. All the best, sir. Thank you so much for gracing the occasion and being with us.
Thank you.
Nilima, if we can have the slide share again. Yeah, so let's begin with the first session. And this is going to be chaired by two experts slash mentors. Dr. Tushar Kar, sir, is the past chairperson of ICOG. He was also a vice president of Foxy, and he was a chairperson of the Foxy Oncology Committee way back from 2004 to 2009. He's also a national corresponding editor of the Foxy Journal, that's Jogi, and he is well known to all of us in academic circles. He's a very eminent and reputed professor. And I remember the ICOG annual conference, which was conducted in Bhubaneswar under his guidance. And I have fond memories. I still have pictures of that on my Facebook, which keep popping up every November. Like, okay, so many years ago, you were here in Bhubaneswar with Dr. Tushar Kar. So really happy to have Sir with us, and he's a fantastic teacher. I'm sure the students will have a lot to gain by his insights. Next slide, please. Dr. Ramani Devi is well known to all of us. She's an eminent teacher, and to her credit, she also has a Foxy recognized training center for infertility and endoscopy. And year after year, many of our students always stand in the first, second, or third positions in the exams that we conduct at the end of the training courses. She was vice president of Foxy in 2020. She was chair for the endometriosis committee of Foxy, and she did the Foxy GCPR, Foxy ICOG GCPR on endometriosis during her tenure as committee chair. She is also an EC member of the SAFOG Infertility Committee, patron of the IFS Tamil Nadu chapter, and currently the president of TNFOG. Thank you very much, Dr. Ramani Devi ma'am, for joining us. I'm sure the students will learn a lot from you.
Thank you,
Next
Dr.
slide, please.
Prateek.
Yes, ma'am. So to introduce the first speaker of the day, we have with us Dr. Raksha, who is going to be speaking to us on importance of the baseline hormonal profile. To introduce Dr. Raksha formally, she is a junior consultant at the Vasundhara IVF in Jodhpur, and she's done her MS from Safdarjung in Delhi, also studied laparoscopy from Dr. Nitin Ghorpade, reproductive medicine from Dr. Sanjay Makwana, and she's done several paper and poster presentations. Over to you, Dr. Raksha. You can share your screen and get started. Speakers will
Pratik,
have
can I give two
approximately 15
sentences
minutes.
only?
Of course, sir. Of course, sir.
If you
Yes, sir.
allow. Yeah.
Yes,
It's
sir.
a really straight away I'll go to the topic. I must thank Pratik, Sarita, and Parag in a great way. Today I feel that it's a like for a long time it's a family thing. Like me, Parag, Pratik, Sarita, Ramani Madam, I think that it's no more than a family. It's just extended family, and you have brought the academics in different way. And actually, you deserve to be our family members. That much I can say. Let's
Thank you, sir.
continue.
Thank you. So each speaker will have approximately 15 minutes, and after that, the experts and mentors will interact. Over to you, Doctor.
Good afternoon. Sir, am I audible?
Yes.
Yeah, you are audible and visible. Please go ahead.
Yes, sir. Good afternoon, everyone. At the outset, I would like to thank ICOG for giving me this opportunity. I am talking about importance of basic hormonal profile. As we all know, infertility is a growing concern and nearly it affects 10 to 15% of couples worldwide. And the causes can be diverse, ranging from ovulatory factors, tubal factors, uterine factors, male factors, and in some cases, no obvious explanation. A basic hormonal profile is an important step in evaluation. It helps us to identify the cause. It not only helps us to identify the cause, but also provides guidance for the prognosis and also helps us to plan the appropriate treatment strategy for the couple. Let's brush up with the physiology. Hypothalamus releases GnRH hormone in a pulsatile manner, which in turn causes pituitary to release FSH, leading to the development of dominant follicle, which releases estrogen. Estrogen by negative feedback reduces FSH, but persistent and rapid rise in estrogen causes LH surge, which in turn leads to ovulation. Ovulation, there will be development of corpus luteum, which causes release of progesterone under the effect of LH. The raised progesterone levels by negative feedback reduces progesterone and also the estrogen, which leading up to menstruation. And thus, each single process in reproductive cycle is interconnected with each other, and every hormone has its own role. And if there is abnormality in any single hormone, will disturb the whole process. Coming to objectives of basic hormonal profile, it helps us to evaluate ovulatory function and to assess ovarian reserve, that is the remaining reproductive potential. It helps us to detect endocrine disorders affecting fertility and finally to identify correctable hormonal imbalances. Why? Because in some cases, just by treating hypothyroidism or by correcting the prolactin levels, the normal natural fertility can be restored. Timing of hormonal testing is extremely important. On day 2 to day 4, that is during early follicular phase, we measure FSH, LH, estradiol, and AMH. On day 21, that is in mid-luteal phase, we can measure progesterone for ovulation confirmation. TSH, prolactin, androgens, and AMH can be measured anytime. Thus, by ensuring proper timing, we can give accurate interpretation and we can avoid misdiagnosis. Now let us go through some important hormones one by one briefly. FSH is secreted by anterior pituitary in response to pulsatile GnRH stimulation. It stimulates the development of follicles. Normally, on day 2 to day 4, the value ranges between 4 to 8.9 international units per liter. If the value is above 8.9, it denotes the low ovarian reserve. High FSH is a direct pituitary compensation for the older and less responsive ovary. High basal FSH levels should be used for counseling women with regards to their outcome rather than excluding them from IVF cycles. FSH level more than 25 indicates premature ovarian insufficiency. On the other hand, extremely low levels indicate hypogonadotropic hypogonadism. We should also remember the limitations like it doesn't diagnose poor ovarian reserve until high thresholds are reached, does not explain oocyte quality decline, Intercycle and intersample variations may result in a disparity in FSH measurements. Its role is limited in the evaluation of young healthy women. Elevated day 3 FSH involves heterogeneous group, some with true reduced ovarian reserve and some due to the presence of heterophile antibodies, and also some because of FSH receptor polymorphism in patient with otherwise normal ovaries. LH is also secreted by anterior pituitary and it stimulates and has critical role in ovulation. In day 2 to day 4, the value ranges between 3 to 10 international units per liter. LH to FSH ratio more than 2 is an indication of PCOS. Extremely low levels of LH are seen in hypogonadotropic hypogonadism. The surge of value more than 20 denotes that the ovulation is going to occur within 48 hours. Estradiol is produced in the ovarian follicles as they grow. Between day 2 to day 4, the value ranges between 30 to 80 picogram per ml. Abnormal basal high levels of estradiol, that is more than 80 picogram per ml, may indicate existence of a functional cyst or diminished ovarian reserve. On the other hand, extremely low levels will be found in WHO group 1 and group 3. During stimulation, we expect the estradiol levels to raise proportionately to the mature follicles, that is 150 to 200 picogram per ml per mature follicle. However, limitations are as follows. Prediction of ovarian reserve is still debatable by E2 levels. No relationship has been found between serum E2 levels and pregnancy rates. Very low predictive accuracy, both for the poor response or excessive response. Prolactin is also an important hormone. Prolactin gene expression occurs in specialized cells, that is lactotrophs of the anterior pituitary gland, as well as in the decidualized uterine endometrium and the myometrium. Hyperprolactinemia is one of the common causes of oligoanovulation, and the value ranges between 2 to 29 nanogram per ml. Hyperprolactinemia in PCOS requires treatment of PCOS only. TSH must be evaluated before treating hyperprolactinemia. High levels of more than 50 to 100 nanogram per ml need further investigations to exclude prolactinoma. In microadenoma, the value ranges between 100 to 200 nanogram per ml, whereas in macroadenoma, the value is greater than 200 nanogram per ml. AMH is secreted by granulosa cells of preantral and small antral follicles. Unlike LH and FSH, it remains relatively constant throughout the menstrual cycle. Hence, it can be measured in any day of the cycle, and the value ranges between 1.2 to 3.5 nanogram per ml. Very low levels predict low response, whereas greater than or equal to 3.5 nanogram per ml predict high response in IVF cycles. If AMH is very high in PCOS, it predicts ovarian hyperstimulation syndrome. It is indicated in predicting both over and under response in controlled ovarian hyperstimulation. It helps in determining the most appropriate treatment regimen. It helps in pre-treatment counseling for couples to make an appropriate and informed choice. It helps in predicting long-term fertility potential and also the age of menopause. It helps in predicting ovarian aging prior to or following chemotherapy or surgery. However, we should remember AMH test is expensive. There is lack of standardization of AMH assay. There is no role in predicting oocyte quality or live birth rate. Variable AMH measurements made by different AMH assays even when using the same clinical sample. Thyroid health is directly linked to fertility. It has its role in oocyte maturation, ovulation and luteal function, endometrial receptivity, placentation, and also maintenance of pregnancy. Hence, abnormal thyroid function leads to menstrual irregularities, infertility, and miscarriage. The value ranges between 0.35 to 4. Serum TSH and T4 are checked to detect overt hypothyroidism or subclinical hypothyroidism. If TSH is more than 2.5, TPO antibody levels should be measured. Subclinical hypothyroid in a woman who is desirous of pregnancy should be treated with the aim of keeping TSH levels less than 2.5. And hence, we should not miss thyroid evaluation during infertility workup. Evaluation of ovulation can be done by measurement of concentration of mid-luteal progesterone. Other methods such as measurement of LH surge is also used to predict ovulation. Ovulation is most easily documented by a mid-luteal phase serum progesterone level, which should be obtained approximately 1 week before the expected menses. On day 21 of a typical 28-day cycle, the value of progesterone of 3 nanogram per ml is showing that the ovulation has occurred. On day 3, the value should be less than 1 nanogram per ml. An elevated level may indicate a lower success rate for pregnancy. This is a table showing hormones, their timing, and the normal value and the clinical relevance, which is already discussed. The clinical scenarios where hormonal profile helps. In case of hypothalamic anovulation, there will be decreased FSH, decreased LH, and decreased E2. In case of ovarian failure, there is increased FSH, increased LH, and reduced E2. In case of PCOS, there will be decreased or normal FSH, increased or normal LH, or increased or normal estradiol. Hormonal evaluation also has its important role in male infertility workup. We can measure FSH, testosterone, LH, prolactin, estradiol, and TSH when needed. Serum prolactin in case when patient complains loss of libido. Thyroid profile also has role. Hypothyroidism leads to oligospermia and hyperprolactinemia. Hyperthyroidism can cause oligospermia. Diagnostic hormonal levels in male infertility. Low testosterone with high FSH and LH, that is high gonadotropins, is seen in primary hypergonadotropic hypogonadism. Normal to low testosterone with a high FSH is seen in primary spermatogenic failure. When the hormonal levels are normal with azoospermia, that points to obstructive causes which can be treated with surgery. High testosterone and LH but normal FSH can be seen in partial androgen resistance. What are the advantages of early hormonal evaluation? When a couple comes to us with complaint of infertility, the first question they ask is what is wrong with them which is causing infertility? And in many cases, the answer can be found out by simply doing early hormonal evaluation, which helps to detect treatable causes early. It avoids unnecessary invasive procedures, and it also helps to tailor ART like IVF or ICSI stimulation protocols for the couple. In a long term, it is cost effective. It saves time, it saves cost, and it prevents emotional distress for the couple. But we should always remember that hormones are only a single piece of the puzzle. Hormonal levels fluctuate with stress, illness, medications. Interpretation requires clinical correlation and ultrasound. Hormones alone do not determine the fertility potential. Hence, hormonal evaluation is an important backbone during infertility workup. And in many cases, by just identifying and treating simple hormonal imbalances may be a key for achieving pregnancy. I would like to end my talk by telling a quote: a correct diagnosis is 3/4 the remedy. Thank you.
So thank you very much, Dr. Aksha. This is a difficult topic to cover in a short period of time, but I think you did quite well. If we can have comments from Dr. Amni Devi and Dr. Tushar Kar, sir.
Dr. Tushar, would you like to start?
Or should we do all that at the end as per
Yeah.
the program and proceed with the second speaker, ma'am?
Okay,
Whichever way you
okay,
like.
okay.
Let's do that.
That's
I
fine.
think we move to the next speaker.
Hmm.
The next speaker is Dr. Upma Yadav, and she is going to be speaking to us on markers of ovarian reserve. And she is a fellow in reproductive medicine. She has also done a diploma in cosmetic gynecology. She works at the Marigolds Multi-Speciality and IVF Center in Gorakhpur. She has multiple publications to her credit, and she's also teaching faculty for IVF. Over to you.
Good evening, everyone. I'm sharing my screen now. Is it visible, sir?
Not yet.
It's not visible.
No, maybe you can stop sharing and share again. Sometimes there's a technical glitch. Take your time. It's okay. We have time. So you're currently sharing your Explorer window. You'll have to stop sharing and share the PowerPoint window.
So just
Should we go to the next speaker then? I think I saw Dr. Shazia in between. Dr. Shazia, you want to take up the next
Yes.
stop?
Yes, sir, sure.
Okay, so then you can go ahead and share your screen and I will just introduce you. Dr. Shazia Mohammed is going to speak on adjuvant therapies in ART, and she's one of the students from the previous batch. In fact, I think I was her examiner at the last batch.
Yes, sir.
She's a student of Dr. Nandita Palshetkar. She also has a lot of research work, a lot of publications to her credit. She's going to speak to us on adjuvant therapies in ART. In the meantime, I think the previous speaker will get their technical issues sorted. We'll begin with the next presentation. Over to you, Dr. Kalvi.
So good evening, everybody. Thank you so much, ICOG, for giving me this opportunity. And I would like to start with my presentation. So my topic is adjuvants in vitro fertilization. This is a very, very important topic because we all of us are using a lot of adjuvants. So in just a second. Okay. So in assisted reproductive technology, adjuvants, often also called as add-ons, refer to the non-essential interventions administered in addition to the standard IVF or ICSI protocol with aim of improving clinical outcomes such as implantation rates, ongoing pregnancy rates, and live birth rates. These can be pharmacological agents, laboratory techniques, or procedural modifications. They are distinguished from the core IVF steps such as control ovarian stimulation, oocyte retrieval, fertilization, embryo culture, and embryo transfer by the fact that they are not strictly required for achieving pregnancy. We may or may not use them, but are proposed to optimize the success. So the historical context, the concept of add-ons emerged in late 1990s with assisted hatching as one of the first widely adopted interventions for selected cases of repeated implantation failure. Over the past 2 decades, as we all know, technological advances, commercial competition between fertility centers, and heightened patient expectations have fueled a proliferation of adjuvant use. However, while their uptake has been rapid, the evidence base has been lagged behind. Many adjuvants entered clinical practice following small observation studies or mechanical plausibility rather than a large, well powered randomized control trials. So, the classification, so this, I have classified my adjuvants as per the adjuvants that are taken in the periconceptional phase, adjuvants before and around fertilization, like antioxidants, vitamin C, vitamin E, coenzyme Q10, omega-3 fatty acid, melatonin, pentoxifylline, L-arginine, lifestyle and dietary interventions aimed at gamete quality. Then the second was ovarian stimulation phase adjuvants like metformin and PCOS, growth hormones, androgens, testosterone and tear, myoinositol, aspirin and sildenafil. Then implantation and endometrial phase adjuvants like etosiban, growth hormone combination, low molecular weight heparin, corticosteroids, intralipid infusions, intravenous immunoglobulin, endometrial scratching, and laboratory-based adjuvants such as assisted hatching, embryo glue, artificial oocyte activation, sperm selection techniques, time-lapse embryo monitoring when used to guide embryo selection. So we will start. So the rationale for this classification was periconception. It targets gamete competence before fertilization. Ovarian stimulation aims to improve the folliculogenesis and oocyte yield during control ovarian stimulation. implantation and endometrial seeks to optimize the uterine environment and embryo endometrial interaction, and laboratory based modifies in vitro conditions to potentially enhance embryo viability and implantation potential. Let's start with the first one, periconception phase adjuvants. For antioxidants mechanism, it neutralizes the reactive oxygen species. So a lot of research is being done on ROS and their role in the failure at any point, be it the number of eggs that we are getting during pickup, or maybe during the implantation when we are putting the embryo inside. So this is a very important thing. So antioxidants, obviously, it neutralizes ROS in follicular fluids, seminal plasma, and endometrium. It protects the DNA, mitochondria, and membranes and gametes. Evidence, Cochrane review suggests antioxidant may improve live birth rate, but very low certainty due to small and heterogeneous studies. And in men, there is some benefit for sperm DNA fragmentation and pregnancy outcomes, but again, the evidence quality is quite low. So we'll cover the guidelines at when I summarize all the adjuvants. Coenzyme Q10, the mechanism, it improves the mitochondrial function in oocytes, and coenzyme Q10 is widely used these days. It acts as a lipid soluble antioxidant. So not the guidelines suggest it is not specifically addressed by ESHRE or ASRM grouped under antioxidants. Dosing in formulation, we can give 200 to 600 milligram per day orally in divided doses. It can go up to 800 milligram. A very important point that I want to emphasize on is that to use ubiquinol is the oxidized form and ubiquinol is the reduced active form. So when we are prescribing coenzyme Q10, let's all see whether we are prescribing ubiquinol or not, because that is going to be much more effective. As we all know, the drug is quite expensive. Then ubiquinol has a better bioavailability. Smaller dose may achieve similar blood levels, and we can give it for 8 to 12 weeks before IVF cycle and also continue after the implantation. Then melatonin, it is an antioxidant, regulates the circadian control of the reproductive hormones, improves follicular fluid oxidative stress. Again, this also focuses on ROS. Some studies suggest there is an increase in the fertilization rates and oocyte quality. So guidelines not specifically recommend by ESHRE or ASRM, and the dose is 3 to 6 milligram orally at the bedtime. It can be given 8 to 12 weeks before IVF stimulation and also can be continued after that. Pentoxifylline, it improves blood flow, reduces blood viscosity, enhances endometrial perfusion. Guidelines, again, it is not recommended in any major guideline. L-arginine, it is a nitric oxide precursor, vasodilatory effect on uterine blood vessels. So again, it is not recommended by ESHRE or ASRM. Lifestyle interventions is very important. It is not a per se adjuvant, but let's start following this. So mechanism, it reduces the systemic inflammation and insulin resistance, optimizing cardiovascular and endocrine health. The evidence is actually strong observational data, better ART outcomes with normal BMI, non smoking status, exercise, alcohol moderation, and Mediterranean style diet. RCTs limit but are supportive of the lifestyle intervention. And ESHRE lifestyle guidelines suggest lifestyle optimization is recommended for all couples prior to ART. And clinical stance is mandatory preconception counseling for all the patients for lifestyle interventions. This is just the summary. Let's go on the second ovarian stimulation phase adjuvants. Metformin in PCOS, it improves insulin sensitivity, reduces hyperinsulinemia, lowers the androgen levels, potentially improving the follicular genesis and oocyte competence. So evidence suggests in long GnRH agonist protocols, metformin may reduce OHSS incidence without harming pregnancy rate. It's a very important point to consider. In GnRH antagonist cycles, the ESHRE 2025 review finds no consistent benefit for OHSS prevention or live birth rate improvement. So basically, not routinely recommended in antagonist cycle for PCOS, but to be considered in selected high-risk OHSS patients on agonist cycles. But we are all giving in the patients who are at risk of OHSS or are known case of PCOS. It definitely improves the outcomes clinically. Although studies basically suggest it is not routinely recommended. Okay, now growth hormone enhances follicular responsiveness to FSH via IGF-1 mediated pathways. It may influence oocyte maturation. Uh, Evidence in poor responders, mixed results, and normal responders, there is no as such benefit. And ESHRE 2025 states it's not recommended for any responder type outside of the research setting as of now yet. Testosterone priming, it's a short-term androgen exposure, increases granulosa cell FSH receptor expression. Evidence, conflicting trial results, heterogeneity in dosing and duration, and ESHRE 2025, it is not recommended outside trials. Dehydroepiandrosterone, it is again androgen precursor, similar rationale to testosterone priming, and ESHRE does not recommend it routinely. Myoinositol, it is an insulin sensitizing antioxidant, though to improve oocyte competence. Some evidence suggests that there is some benefit in spontaneous ovulation for PCOS, but it is inconsistent effects in IVF cycle. ESHRE 2025 states that it is not recommended in non-PCOS, probably not recommended in PCOS as well. These adjuvants are administered in peri-trans. Okay, now we are going on a third, implantation and endometrial phase adjuvants. These are the adjuvants that are administered in peri-transfer period in fresh or frozen cycles with the aim of optimizing endometrial receptivity, reducing uterine contractions during the embryo transfer, or modulating the immune endocrine environment to facilitate the embryo implantation. Etosiban, so mechanism of action, etosiban is a competitive oxytocin and vasopressin 5-1A receptor antagonist. So in ART, it is given acutely before embryo transfer to reduce spontaneous and prostaglandin-induced uterine contractions, which can displace the embryo and impair the implantation. The biological rationale comes from the studies showing increased uterine time of embryo transfer in some women, especially in cases of repeated implantation failure. Evidence overview, early RCTs and observational studies in 2000s show mixed results. Some improvement in implantation and clinical pregnancy rates in selected populations like recurrent implantation failure or higher uterine contractility, but no consistent benefit in unselected IVF patients. Meta-analysis prior to 2024 concluded evidence was low to moderate quality and sufficient for routine use. Safety, it is generally well tolerated in short-term use. Adverse effects are rare at single-dose regimen used in IVF. So growth hormone in IVF mechanism. Growth hormone acts through the IGF-1 insulin-like growth factor 1 pathway, enhancing granulosa cell sensitivity to FSH. Proposed effects, it the follicular recruitment and responsiveness. It increases the oocyte cytoplasm maturation, and endometrial receptivity is increased via angiogenesis and cytokine modulation. So in poor responders, older RCTs suggest there is improved oocyte yield, sometimes higher pregnancy rate, and recent meta-analysis, Cochrane 2019 update, there is no consistent improvement in live birth rate. Some evidence for higher oocyte numbers, but not translating to live birth rate. And in normal responders, there is no evidence. Safety, short-term growth hormone administration in IVF is generally well tolerated, so there is no as such adverse effects. Okay, then there are the adjuvants that we use for improvement of blood supply, like low molecular weight. The mechanism is anticoagulation with additional effects on trophoblast, invasion, angiogenesis, and possibly endometrial receptivity. Evidence, mixed results in RCT, some improvement in implantation rates in recurrent implantation failure with thrombophilia cases, but no consistent benefit in general IVF populations. There is obviously potentially bleeding risk, and daily injections are an added burden. Guideline stands beneficial in thrombophilia and APS, not supported for routine IVF use. For now, aspirin rationale, again, it is an antiplatelet, vasodilatory, improves uterine ovarian Doppler indices, initially supported by cardiovascular and preeclampsia prevention data. Evidence, early adoption in implantation failure, but meta-analysis and Cochrane reviews show no improvement in pregnancy or live birth rates in IVF. Also, there is no benefit in recurrent miscarriage when high bias studies are excluded. So conclusion, it is not recommended routinely in IVF patients, but again, we are all giving most of the times. Sildenafil or Viagra, it is a PDE5 inhibitor. It enhances nitric oxide mediated vasodilation. Potentially, it increases uterine blood supply and endometrial thickness. So the evidence again, it is not recommended routinely, but may be studied in research settings for thin endometrium. Corticosteroids, it is immunomodulatory, reduces the NK cell activity and inflammatory cytokines. It theoretically is improving implantation rates. Evidence RCT show no consistent benefit in live birth rate for unselected patients. Possible niche in women and with certain autoimmune disorders or elevated endometrial NK cell markers. Obviously, it'll be benefited in such cases. So it is not recommended for routine IVF use. Consider only in research or confirmed autoimmune disease management. Intralipid infusions, it is a soybean oil
But all participants consider that.
inside pelvic sac, like assisted hatching. What is it exactly? It is partial thinning or breaching of zona pellucida using laser, acid thyroid, mechanical before transfer to facilitate embryo hatching. So rationale in some patients, advanced age, prior failure, transfers, then vitrified embryos, the zona may be thicker or stiffer, potentially limiting hatching. Evidence in unselected patients, meta-analysis show higher clinical pregnancy, but no consistent live birth benefit as such. And practical take, it is not for routine use. If your lab already performs assisted hatching selectively, like in the cases of repeat implantation failure, thick zona, or on microscopy, counsel that live birth rate gain is unproven and ensure meticulous laser technique is and documentation. Then hyaluron. So the very common thing, it is called as embryo glue. Transfer media with elevated hyaluron acid to promote embryo adhesion to endometrium, and basically several RCTs and meta-analysis pre-2021 reported improved clinical pregnancy and sometimes live birth rates, particularly in fresh transfers. Heterogeneity and risk of multiplicity exists. Signals appear stronger in certain subgroups, example in forced transfers, but quality varies. Practical take, if considered present as an option with modest and heterogeneous evidence, standardized ET technique like catheter placement, minimal manipulation, because technique effects often dwarf any media tweak. And then this is one thing that we use is artificial oocyte activation, post ICSI activation using calcium ionophore or electrical or mechanical methods when ooplasmic calcium oscillations are inadequate. Indications strongest in total fertilization failure after ICSI, globozoospermia or severe sperm PLC deficiency documented. So in selected indications above, oocyte activation can rescue fertilization and yield pregnancy and live birth rates. In unselected ICSI cycles, it does not consistently improve live birth rate and may pose theoretical concerns. Then sperm selection techniques, physiological ICSI, also known as PICSI. Mature sperm bind hyaluron. Selecting hyaluron acid bound sperm might reduce DNA fragmentation and aberrations. Evidence large RCTs have not shown consistent live birth rate benefit versus conventional ICSI. Consider only if your lab's own data show a consistent advantage in defined activity. Okay. Activated cell sorting, also known as MACS, for apoptotic sperm. Annexin 5 columns remove phosphatidylserine externalized sperm. And evidence there is some improvement in intermediate outcomes, no consistent live birth rate gain for in unselected patients. Now, the new thing that has come up is microfluidic sperm sorting. It mimics female tract flow to select motile, morphologically intact, low DNA fragmented index sperm, and the evidence is promising for lower DNA fragmentation, but clinical live birth rate evidence is preliminary. Quality control matters, obviously. Practical take across methods. These tools can refine sperm quality proxies, but do not reliably raise live birth rate. Time lapse imaging as an adjuvant, so continuous embryo imaging in dedicated incubators, so better culture stability, there is kinetic data, potential better embryo selection than static morphology. TLI improves workflow and reduces handling, but large trials meta-analysis have not consistently shown live birth rate superiority versus good standard culture with competent morphology based selection. So practical take, TLI is a platform choice more than an add-on if used treated embedded algorithm as decision aids, not replacements for embryologist expertise. Avoid over-promising LBR live birth rate gains. Other adjacents like culture media tweaks, mitochondrial boosting, spindle transfer, cytoplasmic transfer, embryo biopsy timing as an add-on, and then putting lab add-ons in context. Um, let's talk about the guidelines. What is the take of the guidelines on adjuvants? On ovarian stimulation, metformin, it is not routinely recommended in PCOS with antagonists, may consider in high OHSS risk with long agonist protocol. This is the statement of ESHRE 2025. Then growth hormone, again, there is no consistent live birth rate increment. It is not, ESHRE again says it is not recommended in low or normal responders. There is no benefit in LBR. So avoid routine use. Testosterone, again, no consistent LBR. DIA, again, no live birth rate benefit. Myoinositol, no IVF LBR benefit. Aspirin, no live birth rate benefit. And sildenafil, no proven live birth rate benefit. So ESHRE recommends to avoid the routine use of these things. And sildenafil is only for research use. Implantation adjuvants, again, ESHRE 2023 states etosaban can be used in research for research purposes or selective patients. Etosaban and growth hormone can be used for research purposes only, and to avoid routine use for low molecular weight heparin, steroids, intralipid, IVIG, and endometrial scratching. Laboratory adjuvants, again, HFEA group states assisted hatching is for the selective use only. For example, in cases, as we mentioned earlier, thick zona pellucida on the microscope or recurrent implantation failure. Again, embryo glue has mixed evidence on live birth rate, and the use should be optional. Oocyte activation, when it is indicated, then we are supposed to use PIXI, IMSI, and MACS. Avoid the routine use. Microfluidics, it is, the evidence is very preliminary right now, and it is basically a research only. So if you see in your lab that microfluidics is improving the rates, we can use it as an add-on laboratory adjuvant. Again, time lapse, it is an optional platform. And that's about it. Thank you so much.
Thank you, Dr. Shazia. Comprehensive coverage of all the different adjuvant therapies, including for both partners as well as the laboratory adjuvants. Large topic, and you did more than justice to it. Thank you for your talk
Thank you so much,
and
sir.
for dealing with the interruptions as well. We'll go back to the previous speaker, Dr. Upma Yadav, who is going to speak to us on markers of ovarian reserve. And if Dr. Shazia can stop sharing, then
Yeah,
Dr. Upma can get started.
इसमें जो बना है as they can see.
Yeah, very good. You can go full screen.
Okay, see.
Perfect.
Here are the things. Good evening,
You can go
teachers.
ahead.
I
Yeah.
feel deeply privileged to be a part of this webinar series of Tarun Abhiyan, and I'm highly thankful from the bottom of my heart to Dr. Pradeep Tamke sir in showing trust in us, and also our faculty members, ICOG governing members, and especially Sunita Tandulkar ma'am, and Dr. Tusharkar sir, Dr. Ramani Devi ma'am, Secretary Dr. Sarita Bhalarao ma'am, and Dr. Parag Bilal sir. So, to my other presenting today on markers of ovarian reserve. It is actually very small topic, and we are dealing with it on day-to-day basis. Ovarian reserve is defined as the number of follicles present in the ovary at any given time. It is indicative of the functional potential of the ovary and reflects the number and quality of oocytes within it. The ideal ovarian reserve test or any test should be cost-effective and reproducible. It should have high specificity to minimize the risk of false positive cases. We all know that at 20 weeks of intrauterine gestation, excuse me, the oocytes number are maximum, amounting to around 5 to 6 million of oocytes. At birth, there is finite number of oocytes. The baby girl is born with 1 million oocytes, and at puberty, there is 3 lakhs to 5 lakhs. Excuse me. Sorry, sir. At intrauterine life of 20 weeks, there is maximum number of oocytes, which amounts to 5 to 6 millions. At birth, a female girl is born with finite number of oocytes around 1 billion, which decreases from 3 lakhs to 5 lakhs at puberty, which then again declines in mid when she is in her late 30s to around less than 25,000. There is a rapid fall in quality and quantity of oocytes to less than 1,000 at the age of 51 when menopause finally strikes her. So decreasing fertility is actually an inevitable physiological process, but still females of same age varies in their fertility potential, and hence the need of these ovarian reserve tests or markers. So these tests allows clinician to counsel and also prognosticate and take appropriate measures for her fertility planning and before her decline becomes irreversible. And they're also helpful in assessing the response to treatment, deciding on the dose of stimulation or the protocol to be used, and also the trigger type to be given and the transfer protocols adopted. So this is a figure which shows the number of follicles and the proportion of poor quality oocytes as the age advances. We see the fertility is maximum in early 20s or till mid 20s. And after 30, the fertility starts declining. And when she reaches in her late 30s, she's already the subfertile group. And late 40s or mid 40s is the time of end of her fertility. And when she presents with cycle shortening and irregular cycles, then oligomenorrhea, amenorrhea, and finally the menopause. So the proportion number of follicles decreases and the proportion of poor quality oocytes increases as the age advances. What is the need of doing this ovarian reserve test? It is said that when the patient is of advanced maternal age, like she's more than 35 years of age, and she's not trying to conceive for the last 6 months, but not able to conceive, she has to undergo these tests. And in sometimes there is genetic predisposition also, like X chromosome Turner syndrome is there, monosomy X is there, or X chromosome translocations are there, or even single gene translocations are there, like in Nobox or USP9X and several other genes are there, which are responsible for decrease in ovarian reserve. And or also very important, it is like FR1 gene, which is seen in Fragile X syndrome, which is associated in the 20% of times with decreased ovarian reserve. And certain environmental conditions are there, like endocrine disrupting chemicals, which we are facing on day-to-day lives, like phthalates or these bisphenol A and pesticides, which causes decrease in ovarian reserve, which might cause decrease in ovarian reserve, and also persistent organic pollutants like PM particle more than 2.5, or heavy metals, air pollutants, cadmium, lead, they might all decrease. Even lower socioeconomic status is seen to be associated with low ovarian reserve. there is a strong family history of early menopause or premature ovarian insufficiency. The patient needs to be investigated. And even in the other hand, the other extreme is PCOS, where there is hyperresponders or chances of multiple pregnancy. So that also have to be kept in mind, and patients needs investigation. But there is history of exposure to toxins like chemotherapy or radiotherapy. In the chemotherapy, alkylating agents and procarbazine are the drugs which might cause decreased ovarian reserve. Or the radiotherapy, pelvic radiation, spinal radiation, whole body radiation, or whether there is more than 10 thyroid exposure might lead to acute ovarian failure. The patient has undergone both pre and post surgery for endometriosis. She has undergone cystectomy, unilateral oophorectomy to know about the reserve of her ovaries. And it might help motivate few couples to start or embark on their reproductive journey, parenthood journey earlier, or help the females who are postponing their family planning. They might be motivated to preserve their oocytes, or if she has a partner, for embryo cryopreservation to preserve the fertility. So these are the indications of the patients who require ovarian reserve testing. Now, the ovarian reserve tests are measured by biological method. We all know the chronological age, and biochemical method. Static method is there, which measures a single hormone level of FSH, FSH ratio, inhibin B, estradiol, antimalarial hormone. The dynamic tests are there, though they are more of theoretical purpose only. For clomiphene cited challenge test, very rapid analogous stimulation test, exogenous FSH ovarian reserve test, and biophysical test, ultrasound, which we use on daily, almost daily in our OPD and then every infertility patient. We count antral follicular count. We can see the ovarian volume, and even ovarian blood flow gives an idea of the result. Histological diagnosis by ovarian biopsy is rarely done. Now, coming to the first marker, which is age. It is the single most important determinant of fertility potential. Actually, it is a surrogate marker of fertility, and it is a best indicator of both oocyte quality as well as quantity. And quality is most seen in younger age, and age gives a very good reflection of the quality of the oocytes. But the limitations are there because there is age of onset of decline of ovarian reserve is variable among female population. We have seen young women with poor ovarian reserve, or even they hyper response on the treatment on the other extreme. So they need to be identified freehand. Also, there is need to identify women of advanced maternal age who have good ovarian reserve so that we can predict their fertility potential. And this is a diagram which shows the interplay of hypothalamus pituitary ovarian axis. Like yesterday, sir was saying that hypothalamus is like a central government, and the ovaries and the pituitaries are like the state government. So the hypothalamus pituitary axis differs in different it differs in the ways when the ovary is either young or the old. If the ovary is young, there are a lot of follicles and the AMH is high, and this causes release of the follicle is recruited, and the estrogen and inhibin B are secreted by the follicles, growing follicle, which causes negative feedback on hypothalamus, and then it decreases the amount of LH and FSH so that further recruitment does not take place. But in the older ovary, the AMH is less. When the AMH is less, the follicle is recruited early. We have short cycles, and the estrogen is secreted, and also inhibin B is secreted, but to a lesser amount by those follicles of the older ovary, and therefore there is less negative feedback effect on the pituitary, and then the FSH value is high, which we see in the test also. So FSH is high in all the patients, and AMH is less. This shows decreasing reserve in the follicle, decreasing pool of follicles. Now, the anti-Mullerian hormone, or the AMH, or Mullerian inhibiting substance, it was first discovered by Alfred Jost in 1940 as a fetal male sex differentiation factor. It is secreted by the Sertoli cells of the fetus to decrease the Mullerian duct, so that the fetus is developed as male fetus, and the Mullerian duct is inhibited. The female organs are not, female reproductive tract is not developed. Its potential for predicting ovarian response was discovered by David Seaford in 2002 and Nelson et al. In 2007. It is a 140 kDa homodimeric glycoprotein of belonging to transforming growth factor beta family. It is derived from the granulosa cells in reproductive aged women, and it is expressed by primordial and very follicles less than 6 mm in size, primordial, secondary, preantral, and small antral follicles, because they are AMH dependent. And after that, when the follicle grows more than 8 mm, it becomes FSH dependent follicular selection. So these are secreted by small follicles only, and gives a very clear idea of the development functional primordial pool of follicular pool of the ovary. At the females, the level peaks between 20 and 24 years of age and then decline until it becomes injectable or very low level at menopause. The AMH levels are indicative of the total available follicular cohort or the functional ovarian reserve of a patient. The clinical implications of serum AMH levels are very wide. They are used in vitro fertilization, which we are using to assess the periods of a patient. Even a general physician can use if the cost does not come in the way. If the patient comes of amenorrhea, we can check the patient, or the PCOS patient with premature ovarian insufficiency, before she embarks on the ovarian surgery for endometriosis, endometrioma, or even it is a marker for granulosa cell tumors where the levels are very high. And it is done before pre and post cancer treatment in the patient to assess the ovarian reserve. How menopause patients can be done, or it can help the couples in planning for their families, or so that they can start their family earlier. But the limitations of AMH being a very good marker, it requires optimal storage and handling, because if we store it for the long time, complement system interference is activated, and which leads to deranged values. What we do, we take the 4 ml of blood by open phlebotomy method and keep it in the room temperature and clock for 30 minutes. Then it is centrifuged at 1000 G for 10 minutes. And then the serum is frozen at minus 80 degrees centigrade and then transported. The AMH Gen 2 assay by Beckman Coulter is a single new two-step sandwich type enzymatic microplate assay, which was developed in 2010 and is current the most standard method of assessing AMH levels. The new method is there, Pico AMH assay, which has even more enhanced sensitivity. It is on the way, and even the dried blood spot DBS method is being developed so that a single prick test can evaluate the AMH. But right now there are lack of standard labs, and therefore the values are different from different labs. Low levels are seen in vitamin D deficiency, use of oral contraceptive pills, or smoking, even alcohol use decreases, endometriosis, endometriomas, ovarian surgery, even mutation and pre-mutation in BRCA1 and FMR1 gene associated with fragile X syndrome is seen. High levels are observed in PCOS, granulosa cell tumors, or disorders of sex differentiation, like premature thalaki or precocious puberty. And also the limiting effect is the cost. It is not cost effective, still a very costly test. And also I would like to say that there is misconception is that it is a cycle day independent variable. Everyone thinks that it can be done at any time of the cycle. It is not like that. It is seen that the follicular phase and the luteal phase AMH differs by as much as 11%. So it should be done in the early follicular phase only. This is the chart which shows AMH levels in nanogram per ml and the ovarian reserve. The levels are normal between 1 to 3.5 for practical purposes. And if it is more than 3.5, it is she's going to be a hyper-responder or potential candidate for PCOS. And if it is low, less than 0.9 to 0.3, she has low fertility, and less than 0.3 is severely in low fertility. Now coming to the next hormone which we can assess is FSH, follicular
Sorry to
stimulating
interrupt,
hormone.
ma'am. You have 2
Yes.
minutes to go.
Oh my God. Follicular stimulating hormone
Quickly.
is a very secretory and radio pituitary. The levels are done on day 2 and day 3. More than 10 international units indicate poor response. More than 40 indicates worse response if single level. And there is high intracycle variability. Sensitivity and specificity is very high. and therefore is not much reliable, more useful for evaluating perimenopausal status. Now, E2 levels vacillate over the course of time. High day 3 E2 levels suggest diminished ovarian reserve. More than 80 and less than 20, both can indicate ovarian failure, and more use in combination with serum FSH. More useful in guiding for us for practical purposes when to start the stimulation in ART. Inhibin B is the same hormone like AMH and measured on day 3, and levels less than 45 suggest diminished ovarian reserve. Antral follicular count is again a very important tool in our hand, and we have to do it in every infertile couple when she comes for examination. It's a part of examination nowadays, and by TVS probe 2.9 mm diameter, the follicles are counted, but the limitations are previous surgery, obesity, or larger cyst and endometriosis. There is high inter-observer variability, but the short learning curve is there, and therefore anyone can master the technique. And it is equivalent to AMH by experienced center and by experienced sonographer. The ovarian volume also gives a very good idea. And volume, if it is more than 10 cc, suggests PCOS, less than 3 suggests DOR. But limitations are against cyst, endometriosis, and previous surgeries or exogenous gonadotropins. And the new methods are there like vocal 3D ultrasound and color Doppler, which can enhance the image quality. Clomiphene cited test, it is a dynamic test in which baseline measure FSH is measured on day 3 and again on day 10, and CC is given from day 5 to day 9. But the results are very not very effective, and it is very costly, and patient compliance might not be there, not a standard test. And this gas test, which glyceride acetate is given, and basal levels of measured on day 2, and then the next day after 24 hours, if it is twice the baseline, suggests normal response and assesses the hypothalamic ovarian axis. More useful in central precocious puberty. And exogenous effort test is then done when we take baseline E2 and FSH, administer 300 IU or recombinant FSH subcutaneously, and then take 24 hours later. If the E2 rises more than 30, it is a normal OV. Progesterone is no longer used. Early PSLS surge and elevation suggest poor ovarian reserve. These are comparisons of various tests, various conditions. And this is sensitivity and specificity shows there is no proper cutoff, no sensitivity, no specificity. So none of the markers is a gold standard. And indicated in evaluation of infertile couples, selection of stimulation protocols, dosing, and to consider elective oocyte cryopreservation, and to before and after gonadotropin treatment, counseling regarding perimenopause, evaluation for premature ovarian insufficiency, and women with FMRG1 gene or BRCA gene. It is not indicated in evaluation of fertility potential as a screening tool for diminished ovarian reserve in low-risk population, or as a predictor of pregnancy or live birth rate, as inclusion or exclusion criteria for use of ART, or individualized counseling on reproductive lifespan. The future genetic ovarian biomarkers are there, which does not have, still they are not in the market, and they're just for experimental use. For theoretical use only, single nucleotide receptor polymorphism for FSH and LH, E2MH receptor gene, no differentiation factor, even granulosa cell gene expression, and BCL6, which is diagnosed, which is for endometriosis. And the commercial kit is also there, receptive RDX, but not used widely. In summary, I would like to say that age is the single random surrogate marker for infertility. AMH and AFC appear to be a better procreative testing method along with age. Abnormal ORT does not necessarily include miscarriage rates, which is 25% higher risk of aneuploidy. It can have negative psychological effect on the female or the couple. Clinicians should be judicious in their use and interpretation, and never deny ART treatment to any patient on the basis of ORT. Thank you, sir.
Thank you very much, Dr. Upma Yadav. Comprehensive coverage of the topic, ovarian reserve testing, and specifically markers of ovarian reserve. I would suggest you can stop sharing your screen, and I will invite Dr. Ramani Devi and Professor Tushar Kar to give us their views, their comments, and their guidance regarding the 3 speakers that we've heard so far, and then we can move to the debate session. Over to you, Dr.
Thank you,
Ramani.
Dr. Pratik, for involving me in this particular program. I think Dr. Tushar is not there. I think
he had to excuse himself. Yeah.
Okay, then to begin with, I think I should congratulate all the 3 speakers. They have done an excellent job. And the basic hormonal profile that was done by Dr. Yeah.
Dr. Raksha.
Yeah.
He was the
She
first
has
speaker.
done a very crisp presentation, I should say, because she has pointed out what are the basic hormonal things, what we have to do. And she has pointed out which hormone is specific for what, if you need to do a hormone, why you should do that. That she has made it very clear. And for a simple basic infertility treatment, when a patient is young, coming for just an advice, I think TSH is a most important hormone. And clinically, we can assess hyperprolactinemia that can also put in. And the basic thing is, apart from the hormonal profile, I think the ultrasonogram is a very, very important tool that should be, because every person has got an ultrasound tool. So that will give you an idea about regarding the fertility potential of that particular patient. So there's also not only that, like measuring the ovarian volume, and now the Sono AVC we have got, and that is able to give us a beautiful picture about the antral count, and it can classify the number of follicles which are less than 2 or 2 to 9. That will help us to plan. Probably, suppose if you find to have a very low that is size of the follicles on the day 2, maybe we can wait for 3 or 4 days and delay this delay the treatment of ovarian stimulation. That will also definitely help. And then again, the other test regarding the hormonal profile, FSH, LH, E2, I think we need to have. And one more thing is, if the patient is obese and if there are features of hyperandrogenism, then probably, especially that patient definitely needs basic evaluation of the blood glucose status. That is very important, because there is hyperinsulinemia. Then after, along with that, the elevation of testosterone, I know it is very difficult to calculate the testosterone level, but probably by the clinical features and the free testosterone, we don't do it, but it can help us to pick up the androgenic status, and then you can start planning the treatment accordingly. Then AMH as a basic hormonal profile, like the last speaker has clearly mentioned that ovarian reserve testing, AMH plays a major role. That we can, one is we can start planning our ovarian stimulation, and we can assess which are the people who are going to go for ovarian hyperstimulation syndrome or not. So that way, all the hormonal profiles are going to be of use. And in the males, hormonal profile, I think in obese male patient, we need to have a testosterone with estradiol ratio. That is very important. And the testosterone, when it is normal, is 10:1. When it is abnormally, when the estrogen level is high, probably these are the candidates who present with oligospermia, and they can be started on treatment with letrozole. So that is one point what I wanted to add up. And then regarding the adjuvants, again, the speaker has clearly mentioned what should be given in the prior to starting ovarian planning, and then during ovarian stimulation, then during the culture, and then post support. So that was very clear. And of course, for each point, she has given what are the points in favor and what are not supportive evidences. She has given it beautifully. Then again, in the role of like antioxidants and melatonin use and pentoxifylline, of course, it is not going to be of any use. But the most important thing is the lifestyle modification. And again, we should understand that all the adjuvants can be given only for a short-term period. See, in patients with oligospermia, if the patient is going to be put on long-term, this CoQ and all those things, ultimately at the end of 6 months, whatever the first sample, it is getting worse. I think all of you would have seen that. So it has only a limited role in improving the seminal parameters. Then in between, I could not log in. And then
And apologies for the technical glitch,
yeah,
everybody.
it's okay. Then other thing she has added about the metformin. I am very sure that metformin all of us use, but it should be used only in the context of hyperinsulinemia. And of course, growth hormone is simply going to add cost only to the treatment, and really is not of much use. And about testosterone, I have been using in the past, but ideally it is not, it should be used only for a short term. So probably for a period of say 15 to 30 days, maybe we can use it. But I've seen some cases having even though the quantity of the oocyte is going to be less, the quality is found to be good, especially in young individuals. And then of course DHEO and the DHEA and then myoinostols, they can be used. And regarding the implantation, there was atosiban has been mentioned. I feel atosiban has got a specific role in adenomyotic patients, because in adenomyosis, we get the contractions are more. Maybe in this specific condition, there is a role for atosiban, and personally, I have not used it. Of course, LNWH, left and right, all of us use the thinking that it might improve, though the evidence says that it should not be used out of the cases who have APLA. But one thing is vitamin D3 supplementation, which is found to be a magical hormone, magical vitamin. I think that can be safely given to all the patients. And intralipids and embryo glue, then oocyte activator, all those things are only in the research setting. I think we can use it, or otherwise probably it is going to add only to the cost for the patients. Then regarding I think the third talk was about the markers of ovarian reserve. The speaker has already mentioned very well what are the markers, and the only if a candidate is asked a question, what will be the single marker which you will prefer, or single or maximum, based on the clinical and the ultrasound finding. I think we have to be on the age of the patient and the antral count. Those two are going to have a clinically valid points. And of course, we have the support with the AMH levels. And the AMH, previously we thought it should be done on any day, but now the evidences are telling that preferably you do it on the day 2. I think this much I wanted to add up. And anything else, Dr. Pratik, you want to add up?
No, I think that was fabulous coverage of all the points by all the 3 speakers, and you added even more. I think there's an overload of knowledge now amongst our audience. Thank you so much, all of you, for fantastic talks. You were more than equal to the task. Apologies for the internet glitches from the backend team. Thank you very much. And I think we will move to the next speakers, who are going to be the debate. We have a live
All
talk.
the speakers have done very well. All the speakers have done very well.
Yes, ma'am. So we have a debate on a topic, and the topic is long agonist protocol is better than the GnRH antagonist protocol. And we are going to set the cat among the pigeons. We have 2 speakers, Dr. Mahima Lalwani for and Dr. Sukriti Singh against. I'd just like to take a moment to introduce the judges. First, we have with us Dr. Pesci Lewis, sir. Sir is a past vice president of FOXI. He is a professor and teacher of reproductive medicine at Amrita Institute of Medical Sciences in Kochi. Also an ICOG governing council member along with me, and recently he's joined Dr. Madhuri Patel and myself as one of the conveners for the ICOG reproductive medicine course. Dr. Seema Pandey is also a dear friend. She's the president of the Azamgarh OBGYN Society, librarian for ISAR, also a managing committee member of ISPAR, and she has several books, publications to her credit on various different topics, including infertility, PCOS, etc. And she is a fellow governing council member of ICOG. Also, she was just very recently one of the co-conveners for the ICOG reproductive medicine course. So we have 2 speakers, Dr. Mahima Lalwani and Dr. Sukriti Singh. Dr. Mahima is a consultant OBGYN and infertility specialist at the Lalwani Mother and Child Care Hospital in Pune. She's done the ICOG fellowship in reproductive medicine, also studied clinical embryology, functional and aesthetic gynecology. She's certified in advanced ultrasound, including FMF certification and multiple presentations to her. So without further ado, let's have Dr. Mahima, who's going to speak for the motion. And after her, we'll have Dr. Sukriti, who is a reproductive medicine consultant from Jodhpur. She studied at various different places, and most recently, she has been working with Dr. Sanjay Makwana in Jodhpur. She has, to her credit, several wins at quizzes, both at local as well as national level, and she was the recipient of the Dr. Gauri Devi Silver Medal in the national quiz at 40 Vision 24, one of our students from the previous batch, and she did very well in the ICOG certificate course as well. So without further ado, since we're already delayed, I suggest we go ahead with the presentations. Dr. Mahima, you can share your screen and get started.
Good evening, everybody. Am I audible and visible?
Audible, visible, go ahead.
All right. So good evening, everyone. Here we move on to our session number 2. That's the debate. So the today's topic is the long agonist protocol is better than the GnRH antagonist protocol. So at the outset, I would first like to thank all the seniors and the Foxy ICOG team for giving me this opportunity. So I'm going to speak in favor of the topic. Before we commence, some basics regarding the long protocol. The long agonist protocol has always been a very historical protocol and a beautiful protocol which we all have been using since ages. So the main mechanism of this long agonist protocol is very simple. It uses the flare-up effect initially, and which is followed by a downregulation. So when the flare-up actually happens, there's an increased secretion of the FSH and LH followed by its decrease. And that actually leads to the prevention of the LH surge, which we all completely desire, and also the abolishment of the FSH secretion, via which we are able to make sure that our follicles are developing only through the exogenous FSH. Stating the whole protocol, the agonist has started in the previous cycle, the mid-luteal phase, that is from the day 21 as seen in the diagram. And then as we reach the menses date, from day 2, the dose of the agonist is reduced to half. The choice of agonist is optional. It is subjective, which everybody would like to use according to themselves. And from day 2, when the dose is reduced to half, it is continued till the time of the HCG, along with the simultaneous administration of gonadotropins, which we're using like that. So it is the gold standard, and there is nothing that we can, not abide by it. As my opening statement, I would like to say, for clinics who are prioritizing transfers in normoresponders, and for women in endometriosis and adenomyosis, the long protocol undoubtedly offers a more synchronous folliculogenesis. It has a superior LH suppression and a higher oocyte maturity. And then most importantly, in many meta-analysis which I'll be submitting ahead, it has got a higher clinical and ongoing pregnancy rate, especially in fresh cycles, with even immunomodulatory effects that can also be seen. So let us dissect the topic one by one. Rationale number 1. It offers a deeper and a more stable LH suppression. Before I go ahead, why do we actually need a LH suppression? There are multiple follicles which we all are aware. So it will have a higher E2 level, and that higher E2 level will have a positive feedback and will cause a premature LH surge, which will decrease our quality of the eggs. So this agonist protocol, it will minimize this premature LH surge and even luteinization and reduce our cycle cancellations, hereby producing a more synchronous follicular growth and improvising our oocyte maturity. Let me go to the studies that were there from the historical time till today. Moving at the first study that is there, it was a study of 1989, 111 cycles. 3 cycles only had early luteinization occurred. And this is the prime point that we need to consider. The fertilization and the cleavage rate was 50 and 95%, and 34 clinical pregnancies were seen out of those. Moving on to the next study that was done in 1992, it also showed that there was an improved pregnancy outcome with the agonist stimulation due to the improvement in the oocyte quantity rather than the quality that was suggested at that point of time. One small thing that was published in the Lancet, apart after that, 1987, which had a very good topic, which said never on a Sunday. That means we are able to program it, the IVF cycle, according to us when it comes to an agonist cycle. And at the BMC Reproductive Biology and Endocrinology, which also had the same 2012 publication, which said that the GnRH agonist versus the antagonist, which said very clearly that there were higher pregnancy rate as compared to the use of gonadotropins. The major benefits were decreased cancellation rate, prevention of premature LH surge and luteinization, the follicular recruitment, and allowing larger number of oocytes, and the improvement in the routine patient treatment protocol. Basically, to sum it up, extended widening of the FSH window is exactly done, which causes an increased number of the recruited mature follicles as well as a higher number of retrieved oocytes. So to sum it up, overall these things that I've said so far about the synchronicity, the maturity, the fertilization rate, the cleavage rate, the quantity, programming, and decreased cancellations. These are the 5-6 pointers which I feel are really important when it comes to the agonist protocol. This was a recent study that was done, which clearly mentioned that yes, there was no significant difference that was seen in the clinical pregnancy rate and the live birth rate amongst the two regimes. But yes, there was a COC complexes and the 2PN formation of the oocytes was found more when it comes to the GnRH agonist protocol. But what about the increased cost and the more number of injections, which we always think when we start an agonist cycle? So here I have a proof of that, which said there was a study in 2020 that was done. About 1638 individuals were there, and there was a decision tree model that was calculated. In that, the direct and the indirect costs both were seen, and in fresh embryo transplantation, hereby saying that the GnRH antagonist protocol had an economic advantage. But when it comes to the long protocol, which considered the cumulative ongoing pregnancy rate as compared to just the embryo transfer rate. So I definitely feel if a patient has become pregnant, the ongoing pregnancy is there, and the cost of that total indirect cost is much more lesser as compared to that of an antagonist. There are other alternatives also that were discovered as per the agonist cycle. Number one was the use of long, that was the low dose agonist protocol, which led to less number of injections, where the dose was reduced. Instead of 1 mg, 0.5 was used. And then after that, when it comes to day 2, even more half dose was reduced. This was truly, truly beneficial for people who had normal BMI. There was something which is called a short protocol, which we often use for poor responders, that we start the agonist from the beginning of the menstrual cycle to just get that flare-up effect of that. And that flare-up effect, when it is added with the other gonadotropins, it helps in recruiting more follicles for those who are there as poor responders. Ultra short protocol has also been there. Ultra short protocol that was given on the day 2, 3, and 4, again for the same effect of flare effect, where the gonadotropins are continued along with it. Here there is a low dose of agonist, the costing is also reduced, and there are decreased chances of OHSS. Another few formulations like microdose short protocol was also there, and the SAS protocol, that is short agonist stop protocol, depending on how it is. Now moving on, we just have to choose the right population. We have to wisely understand which kind of patient requires which protocol. In my case of agonist, the normoresponders can be truly given the agonist protocol. Low AMH patients who have a non-uniform growth, this protocol will help in synchronization. For those patients, we can definitely do an additional pooling cycle for them. If there's a patient who has had a previous cycle with failed antagonist protocol, definitely, and poor M2, where this was used another time, the agonist protocol can easily be used. At the end of the day, what does a blastocyst want? It finally wants to be a person more. Moving on to rationale number 2, that is the fresh transfer. We have to understand that the agonist protocol truly supports the endometrial preparation and receptivity. There is a long down regulation which smooths the gonadotropin exposure, and the synchronization of the endometrium is better when it is compared at the trigger or maybe ET in the fresh cycles. Then for this, the another studies that were already done, the very famous study of Lambach et al. That was there, which compared the population who had done the fresh embryo transfer with normal responders. The live birth rate was and the higher CPR ratio was seen when the long agonist protocol was used. Then another study which was there by the Ilani et al., which was a Cochrane review, that also showed a higher CPR ratio with long agonist protocol, better efficacy when it comes to the fresh ET. And next study that is there, that is the third study, which also proved the same thing. This was a meta-analysis that was there. Basically, 22 RCTs were there. Overall, if we see 300 studies have been compared in these meta-analysis, in which 22 RCTs has been there. So the clinical pregnancy ratio, the live birth rate, and the probability of this population that has been studied for stimulation has definitely gone much ahead when it comes to the agonist protocol. Coming to the third rationale, women with endometriosis and adenomyosis, we are undoubtedly using the long protocol, that is the disease modulation. They benefit from the hypoestrogenic milieu. There is a reduced inflammatory signaling and an improved implantation environment, especially when it comes to the ultra long variants. The studies to support from that was the Johnson, which was the Cochrane study of 2010. 3 to 6 months of agonist pre-treatment was given, which increased the clinical pregnancy rate. There was a Salim Etchen study that was 2026. Again, implantation and CPR with prolonged GnRH agonist. There was a Surrey study that compared the endometriosis and adenomyosis patients, which again mentioned about the implantation and the ongoing pregnancy rate as well. And there was a cohort of studies done in 2010 which had the adenomyosis cohort, which also emphasized on the implantation and the CPR after the prolonged agonist suppression. Moving ahead, if these two protocols which are there, if we are into this Marvel universe and we have a Thor and an Iron Man with us, and if these two protocols are there, there is one thing that always keeps poking us, that was the OHS's free clinic. So we have a solution for that. We can freeze the embryos and use the antagonist letrozole and cabergoline to control the OHSs. Rationale number 4, definitely highly programmable start dates are there. So lab batching can be done for those who are into need of that. And consistent staffing is one more advantage that comes to our rescue. Where the other side is also equivocal, I agree regarding the OHSs, but for the normal responders and disease phenotypes like endometriosis, I would still like to go ahead with the long agonist protocol. And regarding the cumulative live birth with freeze-all strategy that is there, if we all think that there is a freeze-all strategy which is not the protocol right now, obviously they converge in together, but if we still prefer and we still prioritize fresh ET, the long agonist protocol has maintained an efficacy edge and an operational predictability. So the priorities that we as IVF consultants should always look into is our patient safety, ethical practice, what is our take-home baby rate, choosing the right set of patients and avoiding side effects, also the cost factor. My closing remark would be, obviously, antagonists win in the high OHSS risk patients, but when we are aiming for fresh transfers, especially normal responders, endometriosis, adenomyosis, the long agonist protocol delivers a higher pregnancy rate as well as the disease-modifying benefits. Thank you, everybody. And at the end, I would just like to conclude that we have to believe and make it happen when it comes to our patients. Thank you so much.
Thank you, Dr. Mahima, for a very forceful argument for the long agonist protocol. I am one of those people who has practiced in the era where we used to do only the long agonist. The antagonist came much later, as Dr. Pesci Lewis also will agree with me. You will need to unmute, sir. I have sent you a request.
Okay.
Yeah.
Okay. I think, Mahima, you told your points very well. I think points are well taken. And let us, I think, Pradeep, we will hear from the...
Yes, let's hear from the opposing.
Then we will come to a conclusion.
And then I think Seema is not well.
Yes.
It looks like she needs fluid resuscitation. Seema, you shouldn't be in an ICOG meeting.
Seema has joined?
No, it's not. Yeah, I'm here. Hi, Pesci.
You will need some
Excellent talk
renal acid
going
bolus,
on.
looks like.
I'm fine. I'm just tired. That's why viral.
Dr. Suketi, please go ahead. Share your screen. We're just waiting for you. I'm pulling the two judges' legs because they're my friends. And I'm seeing them after some time.
Good evening, sir. Respected chairperson, revered judges, especially convener Dr. Prateek sir, and this August gathering. I am very thankful to the ICOG team for giving me this opportunity to be here, and I hope to do justice to the faith that has been put on me. As far as the long agonist protocol being better than GnRH antagonist protocol is considered, I wholeheartedly refute it. Though my opponent has made good points, I will systematically deconstruct them. Now, I would like to start with saying that Vaidyaraj Namatubhyam Yamraj Sahodara Yamastu Harti Pranan Vaidya Pranan Dhananicham. This Sanskrit shlok calls physician the brother of Yama. While Yamraj only takes lives, the physician can take both life and wealth. This was ancient knowledge. But even today, ICMR recommends no harm as the first principle of therapeutics. Now, when we go towards this letter that was published in the Lancet on August 12, 1978, it changed the course of reproductive medicine forever. Although Sir Edwards and Dr. Patrick Steptoe did not mention the use of GnRH analogues, the world soon realized their need. A short bit of history where 1971 to 72 GnRH analogues were isolated and understood by pioneers Charlie and Gilliman et al. In the early 1980s, where most of our seniors have started their practice, both agonists and antagonists were available, but anaphylactic reactions were associated with early antagonists, and agonists became all the rage by 1990s. Various protocols were developed, as my dear opponent has mentioned. In early 2000s, third generation GnRH antagonists came up, and they had neutral D-uridoalkylyl amino acid at 6th position, which resolved the histamine release causing anaphylaxis issue. So by 2010, several systemic reviews and meta-analysis had propped up, which my opponent has mentioned, but with conflicting results. Finally, in 2016, Cochrane sided with antagonists. And by 2019, Eschrey strongly recommended the use of GnRH antagonists over agonists for majority population. Even in 2025, the Eschrey update is still set to choose antagonists as first line, as we saw in the stakeholder review. And there has to be a reason why no new changes have come in the recommendations of Eschrey over past 6 years. Now, there is this short revision of what the protocols are and the mechanism of action of antagonists, which act directly and rapidly inhibit gonadotropin release within several hours through competitive binding to pituitary GnRH receptors. Now, this property allows their use at any time during the follicular phase, which helps us in a lot of ways, whether it is fertility preservation, elective oocyte preservation, or duostem even. Now, the advantages of antagonists are actually innumerable, but I have tried to classify them as these people save time, they save money, and most importantly, they save lives. Since no pre-treatment is usually required and a fewer days of gonadotropin are needed, the cycle duration becomes shorter. And as far as money is concerned, now my friend has mentioned a cost-benefit analysis, but we will get back to it later. Lesser number of injections, lesser dose of gonadotropin, lesser monitoring visits, and especially lesser complications definitely save money. And most importantly, saving lives, as OHS's risk is significantly less with antagonist protocols. It keeps the pituitary responsive to agonist trigger, and also hypoestrogenic symptoms are rare as it is only given for 3 to 5 days. Now, coming to the evidence of equal efficacy. This landmark study, published in Human Reproduction Update in 2006, is what started it all, and we can see how it has stood the test of time. My friend has also mentioned the same study by Bianchis, but they clearly told that there is no significant difference in the probability of live birth between two GnRH analogs, and this result remains stable in their subgroup analysis. Coming on to more recent ones, this is the largest amount of evidence encompassing 73 RCTs and 12,212 women, given by Cochrane, the Al-Enani group that finally gave the update in 2016. They measured efficacy as live birth rate, and you can see the diamond is right in the center with no statistically significant difference between both protocols. Whereas this study by C.B. Lambach, again mentioned by my friend, does give it the risk ratio to be 0.9, but it is almost equal as the diamond is still touching the line of null effect. So they also did a subgroup analysis for PCOS and poor responders, and we can see they are all equal. When we come to the safety of antagonist protocol, there is a large body of evidence available. I have chosen only to present the recent and largest ones, as most of the other evidences presented till now were in the 90s. So this Cochrane review, taking into account 36 RCTs in 2016 by Al-Enani, vanquishes any doubts one might have regarding superiority of antagonist protocol in this aspect. As we can see, the odds ratio is 0.61 and the diamond is far away from the null effect line. Similarly, we may also consider this recent meta-analysis by a Syrian group published in Nature in 2022, considering high-risk women for OHSs, that is women with PCOS, and moderate to severe OHSs, the risk is only
So,
Some
Gurudev, your
network
voice is
issues,
not
I
clear.
think. Yeah, some network issues, I think. We'll just wait.
So can I continue?
Yeah,
Yes,
yeah,
yes.
please go ahead. I think there was an audio failure.
Continue from previous slide.
Okay, so this study was presented by a Syrian group in nature.com by 2022, which considered high-risk women for OHSs. And when they saw the moderate to severe OHSs group, we can see that the odds risk ratio is far away from the null effect, with only 0.65 in the favor of antagonist. Now, coming to the maternal and neonatal safety factors, I found this huge Chinese study with 700 women in antagonist group and 588 in agonist group, though they matched it comparing the PSM problems. And the multiple pregnancy rate as well as the miscarriage rate are both significantly lesser in the antagonist group. While maternal complications seem to be same under both protocols, neonatal complications are slightly higher in the agonist group. Now, genetic and molecular advances. A single-center retrospective study called into question the safety of antagonist protocol by showing increased embryonic aneuploidy in that group. Let me clarify that this did not prove causality. I would now provide further proof of the actual positive effects of antagonists on oocyte quality, gene expression, and molecular chemistry. These are all recent studies where this one is cumulus cell gene expression. This study evaluated 359 genes in M1 and M2 oocytes and focused on AMH receptors, FSH receptors, VEGF, and SRPINE2. They also found new genes connected to cell adhesion and neurotransmitters such as dopamine, glycine, and GABA. And all of these were either higher in the agonist group or they were equal with no significant difference in expression, which is reflected in no significant difference in live birth rates also. There is another study, which is an RCT by an Iranian group published in 2014, which focused on expression of genes involved in cytoplasmic maturity, ATP production, and anti-apoptotic process in GV oocytes, which were all significantly higher in the antagonist group, which means that antagonist group protocol might end up with more mature and better quality oocytes, even though my opponent also said in one of her studies that quantity probably, but quality is lesser for agonists. Then the cost effectiveness, the most controversial thing. Now, this Chinese study, I would like to present my rebuttal on the cost effective study quoted by my opponent. This study was published in 2020 in Nature Journal. It established antagonists as more cost effective in fresh cycles. In fact, here is the exact abstract that was published, which my friend had said that fresh maybe agonist should be considered, but here it is. Again, I would like to remind you that this is a single center study. It is a retrospective study, and they went for cumulative pregnancy rate rather than live birth rates. And most important, quality adjusted life years, which is actually the cost of IVF, was not even considered. And this study themselves, as I've highlighted, they have mentioned that if you take quality in the counting, then antagonist protocol fares far better. Then finally, the question is, which group are we talking about? If it is hyper responders, several studies have shown the benefit of antagonists due to their safety profile and the ability to use agonist trigger. In normal responders, we should consider the comparable efficacy, higher safety, ease of use, less monitoring, cost effectiveness, and this also goes for donors and elective oocyte preservation, or whether it is fertility preservation. Only in poor, and now what Eshrey likes to call them low responders, it is the only group where agonist protocol is still considered, even though both are considered equally effective. Synchronization is now possible with antagonists too, and so is dual trigger. And now that I have recently mentioned all the genetic studies, we can assume that antagonist protocol is probably producing better quality oocytes too. So this is just a reminder of the ESHRE guideline, and we can see how clearly they have chosen antagonist as their first choice in normal and high responders, and even in low responders, they've given equal chance to it. So when we say that long agonist is better, definitely not. Now, I would like to show another slide with the Indian Fertility Society, which has said again that antagonist and agonist are both equally recommended for poor responders. Coming back to the shlok I said in the beginning, Vaidyaraj Namatubhyam Yamraj Sahodara Yamastu Harti Pranan Vaidya Pranan Dhanani Cha. While this acknowledges the power of a physician, it also emphasizes our potential for both healing and loss, imploring us to consider safety and cost both. In conclusion, GnRH antagonist protocol is actually superior to long agonist protocol in most clinical situations, as it is patient-friendly, it is doctor's best friend, and with oral antagonists on the horizon, this is the future of stimulation. Thank you.
Thank you to both the speakers. We will now hear from the judges. Dr. Percy Lewis and Dr. Seema Pandey.
Okay. I think Sukriti, you also put your point correctly. I think both the protocol, agonist and antagonist, has its own advantages and disadvantages. And in a nutshell, if I take it, for hyperresponders, definitely we can tell it as it will be a antagonist protocol. So because we have got an option of agonist trigger, and as Dr. Sukriti told, both the results are comparable in most of the studies. But in for a cumulative pregnancy rate, I feel because of that, the cost factor, when we look into that, I think agonist is the best for, especially for normal responders. And also in poor responders, there are good things and bad things with that. So I think larger studies is needed for the poor responders. So that's what I feel. So I think both the points are well taken. Both had presented very nicely. I think you had taken effort in getting all the data and how the each treatment evolved also. Over to you, Seema, for your comments.
Seema, you can join us. Please unmute. I have sent you an unmute request in case there's some technical issue.
Seema, please unmute. We can see you.
Yeah, hi. So this was an excellent debate, and I am a very strong proponent of antagonists for all until proven otherwise. But the motion which Dr. Arya has proposed, that was really well taken. But the way Dr. Stuti has just dissected it, both were really nice. And the message I would like to conclude with these two talks is it is time for individualization, and majority of us at present are, as she rightly said, that trying to do no harm along with giving them results, because it is not an emergency or life-threatening process which we are dealing with. So our first concern is
So Seema, I think your voice is.
Yeah, I think she has some network issue.
I think I want to slightly differ with Seema, because I usually, as I told, for normal patients, I like to go for an agonist protocol because of the cumulative pregnancy rate and the number of injection may be more, but definitely with the advent of AMH, and when we can and see the antral follicle count, if you are having a slight chance of hyperresponders, definitely we have to go for an antagonist protocol. As Seema told, it is for the patient safety purpose. Otherwise, for other low responders, if there is especially even for the normal responders and even for the low responders, because number of oocyte available and cumulative pregnancy rate is, I think, better with the agonist protocol. So both has got as speakers.
Can you
No,
hear
no, I'm
me?
not telling.
Yeah,
I'm
Yeah,
telling.
we can
hear
hear you,
me?
Seema. We can hear you. I think you switch your audio, your video off. The audio
Oh,
will
yes.
carry better.
Okay.
Switch the video off. I'm
So,
telling both the
like,
things has got its own points, and both the points has to be seen. And as you rightly told, we have to individualize the stimulation protocol and decide, but not as a as a blanket. We cannot tell antagonist better or agonist better. We have to individualize. Now it is very easy with the advent of the scan more now with the how you assess over reserve, how you assess the AMH level, and whether, as Dr. Mahima told, whether you are doing in batches or whether how you can tackle if there is I mean, how you can convince the patient we have to freeze, and if we have got the time, definitely we have to in patients who are going for hyperresponders, we have to go for an endogenous protocol.
Percy, can I
Thank you, Dr.
speak?
Percy.
Yeah.
Yes, Dr. Seema, go ahead.
Your voice is breaking in between.
Yes. So, yeah, whatever. Can you hear me now?
Yes, we
Yes,
can
What
hear you.
I
Go ahead.
need to say, yeah, that two things which are very important. The difference between agonist and antagonist protocol is 1 to 1.5 and slightly better clinical pregnancy rate, though live birth rate remains same. The most important thing for me is the flexibility of choosing a trigger. And if in this era, when if you talk about poor responder going for dose stimulation, these both of the points are very important for patients where if their safety is important, and for beginners, antagonist is a better protocol as per my experience, because with this agonist protocol, sometimes oversuppression happens. You don't understand what to do. Your HMG is not. Recently, I came across a patient where recombinant LHFSH did not work. I did not get any recruitment, and I was really depressed what to do. And in those scenarios, antagonist gives you better result, and it is better to start with. And once you get experience and you know where to individualize and how to do it, for today it is better that we go for antagonist protocol with freeze all in all our hyper-responder patients. Antagonist protocol for normal responders with good glucose support, we are getting good results, and that is my take on.
So thank you, Dr. Seema. I would like to acknowledge the presence of our Governing Council member, Professor Dr. Durga Shankar Das from Odisha, and his comment is that both the debaters were excellent, irrespective of the conclusion of the judges. Kudos and hats off to both of you. Thank you, Dr. Durga Shankar, for being here with us, and thank you for your encouragement. Dr. Seema feels both are winners. Dr. Pesci, your final comment before we propose the formal vote of thanks.
I think, as I told, both the speakers put their points very well, and they did real justice
So prizes
to
to be awarded to both. You have declared a
Yes,
tie.
I think I cannot tell which is better. But if there is an audience poll, we could have taken that. But unfortunately, because it is a Zoom, we don't have facility to take an audience poll. Otherwise,
No.
definitely we could have taken audience poll.
So thank you both the debaters. Thank you both our judges. As the convener for today's ICOG Tarun Abhiyan CME, I would like to present the formal vote of thanks at the end of the day's play. Let me begin by expressing my gratitude to our FOXI President, Dr. Sunita Tandurwadkar, ICOG Chairperson, Dr. Parag Biniwale, Secretary of ICOG, Dr. Sarita Bhalera, both of who were present despite having other commitments. I'd also like to express my gratitude to the ICOG and FOXI team for giving me the opportunity to be the convener as one of the coordinators of the ICOG Reproductive Medicine course for a very long time, along with Dr. Madhuri Patil, Dr. Tushar Kar, our past chairperson of ICOG, and Dr. Ramni Devi, who's our past vice president of FOXI and ICOG Governing Council member, were the experts/mentors for the first session. 3 excellent talks by Dr. Raksha, Dr. Utma Yadav, and Dr. Shazia Mohammed on 3 very important topics. in reproductive medicine. We had some technical issues, but I think they carried the day beautifully, and three very good, excellent evidence-based talks, which are also appreciated by the experts. And you've just heard a wonderful debate from two rising stars. You're going to see all of these five youngsters more and more on the national stage in the years to come. If you guys are not already ICOG fellows, then I would strongly urge you to apply for the ICOG fellowship very soon and receive it as soon as possible. Contribute to the future activities of ICOG, and maybe one day you will be in the place of Dr. Pessi and Dr. Seema, who are the judges for the debate. Last but not least, thank you very much, audience and the backend team, for all your hard work and efforts. We will see you, all of you, soon in the next one. Until next time, goodbye, God bless, and bye for now.
Thank you, Pradeep.
Thank you, sir. Thank you for being here, despite having to log in 4 times.
No problem. Okay. I
Thank
still
you,
now I
Dr.
have
Mahima,
logged with
Dr.
my
Pradeep,
mobile
both of
also
you.
to be on safer side. Logged with mobile. Okay, thank you.
All right, everybody. Bye then. Take care.